Good afternoon, ladies and gentlemen. It gives me great pleasure to welcome you to the second day of the 10th International Neonatology Conference right here in Abu Dhabi, Neonatology Conference 2020. We'd like to thank you all for joining us, and thank you for all who joined us yesterday in the first four sessions of the conference. Today, we encourage you to stay with us for more interactive lectures and discussions. Spearheading this event is Dr. Junaid Khan, chair of the conference and currently the chief of service pediatrics NICU at Al Rahma Hospital, Abu Dhabi, United Arab Emirates. Ladies and gentlemen, it's given me great pleasure to introduce him to start with the welcoming remarks. Good morning, Dr. Junaid.
It's a great pleasure to have all of you in the second day of the conference. A lot of good feedback. Yesterday, I received from the yesterday sessions, all of the participants all over the globe really enjoy. Thank you very much, and especially the panel discussions. Uh, I think the interaction session, the question answers, we got a lot of questions from the participant, but because of the timing, we can entertain a few, and we cannot deal with all the questions because of the time restrictions. Anyway, if you can send your questions, if it is not answered during the panel discussion, then send your questions by email to the MENA conference, and we will send it to the respected speakers. Now, today, again, we have three sessions, very good, excellent talks gathered together for all of you. Remember, all participants try to be interactive, and for a little incentive for that, in the end, we will announce the winner like yesterday, who is the most interactive and with these sessions. Without further ado, it's my pleasure to introduce Dr. Ola Sagastad. I think everybody know if you are practicing the field of neonatology, Dr. Ola Sagastad from Norway. He's the professor, director, Department of Pediatric Research, head Department of Pediatric Research, University of Oslo. He was in medical school in University of Oslo and the postdoc University of California, San Diego. He's a member of many major societies. He published extensively, more than 412 articles, 36 reviews. He recorded in PubMed more than 8,500 citations. So it's a really extensive work in the field of neonatology. A series of books and chapters he already published. He is the honorary member of all the major societies in the Europe, like Hungarian Association, Norwegian Society, Finnish Society, European Association of Perinatal Medicine, American Pediatric Society, and German Society of Perinatal Medicine. It's my pleasure to ask Dr. Ola Sagastad to start his talk. Uh, Dr. Ola, it is all yours about oxygen therapy in the newborn.
Thank you very much, Junaid.
Sorry, doctor. One moment, please. Holding slide.
Thank you very much. Thank you, Dr. Junaid, for first of all for the invitation and also for the kind opening remarks. I'm so happy that I could give this talk because I have so many good memories from previous days in the Emirates and especially Abu Dhabi. So I would like to thank you and Dr. Ayman for organizing this and inviting me to talk about oxygen therapy in the newborn period. So here are my disclosures, and here is an outline of my lecture. And as you understand, during 30 minutes, I can't go into details in all these issues, but I'll touch upon several of these. So for those of you who are interested in the field, here are some of the most recent articles from my collaborators and myself. And I think you can find much of what I'm saying there. If I may draw your attention to this issue of seminars in fetal and neonatal medicine, the whole April issue is dedicated to oxygenation of the newborn. So we try to set up the goals of oxygen therapy. And I think there are four goals, at least four goals. And the first, of course, the most important is to provide sufficient oxygen to the tissues and avoid anaerobic metabolism. And then to prevent hypoxic pulmonary vasoconstriction. And also, of course, to promote brain and somatic growth. And I guess every neonatologist also know that we have to minimize the adverse effects of oxygen, because oxygen is not only critical to life. All of you know that too much oxygen in the newborn can cause oxidative stress, contributing to lung injury and disease as bronchopulmonary dysplasia, retinopathy of prematurity, brain damage or impaired brain development, and damage to a number of other organs as the heart and kidney. Now, just a very quick biochemical update. As you know, this is from the mitochondria, and as you know, in the mitochondrial membrane, you have the electron transport system. Oxidative phosphorylation finds place here. Excuse me. And what happens is that when the electrons are moving from one of the complex to the other, protons are pumped across the membrane and generating a gradient. So here at the fifth complex, this process is reversed. So electrons are accepted by oxygen, so water is generated, and then ATP is produced. Now, some of these electrons, they leak out and react with oxygen and generate reactive oxygen species, which can be neutralized by antioxidants and antioxidant enzymes. However, when we give oxygen, more electrons leak out and more reactive oxygen species are generated. In addition, less ATP is generated. So this was a quick course about hyperoxia. Now, many years ago now, it's more than 30 years actually, I suggested that maybe there is an oxygen radical disease of neonatology. And the idea was that oxygen radicals may attack a number of organs, perhaps at the same time of the newborn. And at that time, I was mainly interested in one oxygen radical generating system, the hyperxanthine oxidase system. Today, we know that free radicals and oxidative stress is generated by a number of sources mentioned here. And of course, inflammation is very important in this process. So the idea was that free radicals attack different organs and may contribute to intraventricular hemorrhage, periventricular leukomalacia, retinopathy of prematurity, bronchopulmonary dysplasia, PDA, neck, and so forth. Well, I think there is evidence that oxidative stress, at least, is associated with all these conditions. But the last 30 years or so, I've been mostly occupied with this question: how much oxygen should we give to newborn infants in need of resuscitation? I will summarize the evidences we have, both for term and preterm infants. Now, in 1953, Virginia Apgar proposed her APGAR score. And if you look at her original paper, you see that 20% of these babies, they received oxygen by some method. So they were using a lot of oxygen, more or less routinely, I would guess, to newborn babies at that time. So in order to achieve a high APGAR score of 9 or 10, a newborn baby has to be pink, as you all know, but at the age of 1 minute or 2 minutes, there's only one way to make a newborn baby pink, and that is to give oxygen. And this is what happened. A lot of oxygen was given to newborn babies, and many of them did not need supplemental oxygen. If we look at the normal transition, we know that the fetus is in a hypoxemic condition, a low PO2, saturations between 50 and 65%. And during the normal transition, the pulmonary hypertension resolves and there is a gradual improvement in oxygen saturations demonstrated here. So cyanosis is normal during fetal life and for the first few minutes after birth. So that's the reason I question whether it's really possible to have an APGAR score of 9 or 10, at least at 1 minute, maybe also at 5 minutes. So if we look at how the oxygen saturation develops in normal babies, the first 10, 15 minutes after birth, you see that if you look at the upper curve here, the preductal saturation levels, you see that even at 2 minutes, the mean saturation is just a little bit above 70 with a wide variation. And even at 5 minutes, many of these babies do not have a saturation above 80. So what happens if you resuscitate with 100% oxygen? This is from a study in newborn lambs. It's from Richard Linner in Sweden. So what they did was that they clamped the cord of these newborn lambs, and after approximately 10 minutes, the animals were randomized to be resuscitated with either room air, the blue line, or 100% oxygen, the red line here. And you see that if you resuscitate with 100% oxygen, you get this enormous PO2 peak, very high. And by contrast, if you resuscitate with air, you get this more slow physiological adaptation here with the physiological PO2 after a few minutes. So if if we go to the world map of newborn resuscitation, it looked like this before 1998. All guidelines recommended to use 100% oxygen for newborn resuscitation. What happened in 1998 was that the so-called RESER-2 study was published, where we had randomized 600 newborns who needed resuscitation at birth to either air or 100% oxygen. And we were able to show that, yes, those who received air did as well as those with 100% oxygen. So in the old days, that is before 1998, provided oxygen was at hand, 100% oxygen was given. And if oxygen was not at hand, many places no ventilation was even tried. So these babies just died. And those who were ventilated, they had this enormous PO2 peak, as I've shown here. Now, many people had objections to the idea that we should resuscitate newborn, and I'm talking about term babies now, with air. So the two main objections was that, first, that when you lack oxygen, supplementary oxygen is needed, and that is of course correct, but perhaps you shouldn't give more than you need. And then the second comment or objection I got at, I think, almost every meeting where I talked about this was that you have to give oxygen in order to reduce pulmonary vascular resistance. And that is true. Abraham Rudolph in San Francisco showed already in 1966 how pulmonary vascular resistance decreases with increasing PO2. This is in newborn calves. And what you see here is that when you reach a PO2 around 40, 45 millimeter mercury, you don't get a further decrease in pulmonary vascular resistance. And if you increase the PO2 to very high levels, it seems to, the pulmonary vascular resistance seems to even increase. So above a certain level, you don't need to increase the PO2 in order to reduce pulmonary vascular resistance. And you find exactly the same pattern for pulmonary arterial mean pressure. So when we finished the RESET-2 study, there were several other studies, other groups who carried out similar studies. So here is from a meta-analysis we published in 2008. The first meta-analysis was a Cochrane review published by Peter Davis and his group in 2004. And we basically found the same, but here we have included more patients, more than 2,000 patients, and totally 10 studies. And what we found was that there was a decrease in mortality of 30% if you resuscitate with air compared with 100% oxygen. So the world map started to change relatively slowly. The first country which changed from oxygen to air was Canada in 2006. A few months later, Australia followed, changing their guidelines, and then Sweden, Finland, UK, the Netherlands, Spain, Russia quickly changed. Many countries said we will choose something in between. And some countries were very resistant, as for instance, US, where they didn't want to change from 100% at that time. So in this period, some babies who were resuscitated got this very high PO2 peak shown down here, and then some got the more physiological approach. However, in 2010, 10 years ago, yesterday, ILCOR came out with new recommendations, and they said that in term infants receiving resuscitation at birth with positive pressure ventilation, it is best to begin with air rather than 100% oxygen. So then the world map changed to something like this. All guidelines changed and recommended to start with air, and we got this more physiological approach with a slow PO2 increase. So we tried to illustrate what happens when you resuscitate with air or 100% oxygen. So if you resuscitate with air, you get this more slower normalization of PO2 up to physiological levels. Some free radicals are generated. However, when you resuscitate with 100% oxygen, you get this enormous PO2 peak and also a wave of free radicals. And this affects the child with cerebral vasoconstriction, brain inflammation, pulmonary vascular reactivity increases, as I mentioned already, and it's also been shown that you get myocardial damage and acute renal injury. And hyperoxia, the first minutes after birth, is also associated with childhood leukemia. Now, a year ago, a new meta-analysis came out from the ILCOR group by Welsford and co-workers, but it basically analyzed the same data as we had, but they had a little bit fewer patients than we had in our meta-analysis, but they found basically the same as we did 11 years earlier. There's approximately 30% reduction in mortality if you resuscitate with air compared with 100% oxygen. And these authors stated that there will unlikely be any further studies on this topic, and that might be true, but we know that science moves on, and it might be that new studies could be needed in order to kind of tease out if there's any groups or subgroups who or even among term and near-term babies who would need extra oxygen during resuscitation. But in general now for term babies, we recommend that resuscitation should be started with air. What about preterm infants? That's a little bit more complicated. And the reason for that is that, as you all know, the preterm baby is different. And I will not go into detail, but just point out that preterm babies, they react differently to hypoxia. They go directly into bradycardia often, which may contribute to intraventricular hemorrhage. And they don't tolerate hyperoxia as well as term babies because they have a lower defense against oxidative stress. And we know that their thoracic cage is different than term babies. It's softer, muscles are weaker, and they lack surfactant. So there are many differences between term and premature babies. In 2010, ILCOR stated regarding preterm babies, because many preterm babies less than 32 weeks will not reach target saturations in air, blended oxygen and air may be given judiciously and ideally guided by pulse oximetry. So you see here that ILCOR doesn't say anything about which FiO2 you should start with and which saturation targets you should aim at. 5 years later, ILCOR was more specific regarding preterm babies, and they wrote then, we recommend against initiating resuscitation of preterm newborns less than 35 weeks of gestation with high supplementary oxygen concentrations. And we recommend initiating resuscitation with a low oxygen concentration, that's 21 to 30% of oxygen. I just also want to show you the European recommendations published a year ago. Oxygen should be controlled by using a blender, and initial FiO2 of 30% is appropriate for babies less than 28 weeks gestation and 21 to 30% for those between 28 and 31 weeks, and adjustments guided by pulse oximetry. Now let's look at the evidence for these recommendations. So the first question is, of course, how should we stabilize or oxygenate very small babies? This is from data from a study published from Max Vento's group more than 10 years ago, babies less than 29 weeks. They were randomized in the delivery room to receive 90% or 30% oxygen, provided they needed positive pressure ventilation. And you see here that after 3 or 4 minutes, there's no difference in the FiO2 because FiO2 was adjusted according to the saturation and heart rate. There's no difference in heart rate. And surprisingly, there was no difference in saturation either between these groups. Now, 3 years ago, we published a so-called torpedo trial, which is, I think, the largest study to date to study this issue. And in this trial, infants less than 32 weeks were randomized in the delivery room to air or 100% oxygen if they needed a positive pressure ventilation. Now, we didn't find any difference in mortality when we looked at the whole cohort of babies. However, when we did a post hoc analysis and looked at babies less than 28 weeks separately, we found that those who had been started with room air had an almost fourfold increased relative risk for mortality compared to those who received 100% oxygen. Of course, that was very concerning. So we carried out several reviews and meta-analysis to try to collect all the data which had been published at that time. So I will show you results from one of our most recent meta-analysis where we compared outcome of babies who received a high FiO2 initially, that is 60 to 100% oxygen, versus a low FiO2, 21 to 30%. So here's the flow diagram. I will not go into details here, but there's approximately 8 studies included in our analysis. So if you look at mortality first, and these are babies less than 32 weeks, you see there's absolutely no difference in mortality whether you start high or low, relative risk 0.99. And when we look at some secondary outcomes, again, there was not much difference between the groups, but we have to keep in mind that these studies were not powered for the secondary outcome. So there might be, we might need more patients before we can draw conclusions. There is a tendency to less BPD if you start with a low FiO2. Intraventricular hemorrhage is no difference between the groups. ROP, no difference between the groups. But there is, again, a tendency to more necrotizing enterocolitis in the low saturation group. For patent ductus arteriosus, there was absolutely no difference between the groups. Now, after that, we became interested in how the saturation should develop, especially the first 5 minutes. And the reason for that was that we found in the torpedo trial that those babies who did not reach a saturation of 80% within the first 5 minutes of life, they had a significantly higher incidence of death or disability, which was the primary outcome of that study. So we see here that adjusted odds ratio for the primary outcome, death or disability, is 0.50. It's a 50% reduction, provided the child reaches a saturation of at least 80% within 5 minutes. And when we did follow-up of these babies and we looked at cognitive score, you see that those who did not reach a saturation of 80% within 5 minutes had a significantly lower cognitive score, more than 5 points, which I think is quite substantial. So what we have done is that we have tried to analyze and follow the cohort of more than 700 babies from 8 studies. And in this cohort, some babies have been resuscitated with air, some with 30% oxygen, some with 60%, and some with 90 to 100% oxygen. So we looked at different gestational ages, and here we have the data for those about 29 weeks, between 29 weeks and 32 weeks. And you see how the saturation develops the first 10 minutes of life according to which FiO2 which was started out with. Now the shaded area here is the targets recommended by the American Heart Association, and these shaded circles, the targets suggested by the European Resuscitation Council. Now, none of these are really evidence-based. It's the best guess, but still it's interesting to see that all the groups, they were above the targets, except for those who were resuscitated with air. It took 6 minutes before they reached the target. For babies less than 29 weeks, all the groups were under target except for those who were started out with 90 to 100% oxygen. And you see it takes approximately 8 minutes to reach the target. Now, we don't know if this is good or bad, but it's absolute, I think, an observation of interest. Now, for those babies who did not reach the saturation of 80% within 5 minutes, there was a higher mortality. I mentioned already, there's also more severe interventricular hemorrhage, but there was no difference regarding BPD. Now, when we're talking about saturation, oxygen saturation, the first minutes of life, it's more complicated than I mentioned so far. For instance, if a baby is on CPAP, the saturation increases faster than if it's not on CPAP. And there's also a gender difference, sex difference. So girls increase their saturation faster than boys, probably because their lungs are more mature than boys. So now the question is, what should we do? Should we start with a high FO2 to the smallest babies and titrate down, or should we start low and titrate up? Well, this is, I think, is a very hot question in neonatology these days. And it's not an easy answer to give, because if you look here, and this is from a study by Binder Heschel from Austria recently, you see here we have the saturation for those who reach a saturation of 80% within 5 minutes, the upper curve, and those who do not, the lower curve. And you see here, there's not a big difference between these groups, at least not at 3 minutes of age. So it's hard to predict from the beginning which babies will reach the saturation of 80% and which will not do that. And if you look at the FO2 between these two groups, you see that there is absolutely no difference, at least very little. So if you are in the delivery room, you cannot, based on the FO2, say anything about whether the baby will reach a saturation of 80 or not. So some people say that for that reason, we should start high and titrate down. And an extra argument for that is that it's been shown by Stuart Hooper's group in Melbourne that immature infants may need some extra oxygen in order to open the glottis. And very recently, Decker and co-workers, they published a study where they had randomized babies between 24 and 29 weeks to either 30% oxygen or 100% oxygen. So they found that if you give 100% oxygen, these babies have a higher minute volume, shorter duration of mask ventilation, higher oxygenation at 5 minutes, shorter duration of hypoxemia, but a higher FO2 exposure during the first 5 minutes. But there was no difference in duration of hyperoxemia or oxidative stress markers. So these authors, they suggest that it's better to start high and titrate down. But see, it's not a big study, only 44 infants. So we argued against that, and because we know that supplemental oxygen, even very brief, leads to increased oxidative stress. Others have shown that. It leads to inflammation, genomic changes, reduces DNA repair and cell growth, inhibition. And we and others have shown that hyperoxia also induces epigenetic changes. We don't know if these are permanent or not. But on the other hand, we know that oxygen may be needed in most immature infants, those less than 28 weeks. But we think that we should give it as low and as brief as possible. So my view is that we should start low, maybe at 30%, maybe at 40%, we don't know, and titrate up according to saturation and the clinical response. So that's the last few minutes, a few words about the NEOPROM study, how we should oxygenate immature babies beyond the delivery room. So the NEOPROM trials ask this question: what is the optimal target saturation for preterm neonates that would result in the lowest death or neurodisability rate? And to answer these questions, 5 studies have been carried out. It was a support trial, the COT trial, and the BOOST trials from UK, Australia, and New Zealand. So in these trials, babies less than 28 weeks were randomized before the age of 24 hours to a low saturation target, 85 to 89%, or a high saturation target, 91 to 95%. So what was found was that in the low saturation target, there was more necrotizing enterocolitis and there was higher mortality before discharge. On the other hand, in the high saturation targets, there was more ROP in need of treatment, but not more blindness. So these results, I think, contributed to the change in guidelines. 2010, for instance, it was in the European, I think also in the American guidelines, that babies' saturation should be kept between 85 to 93%. In 2000 and around 15, 17, guidelines changed to saturation should be kept between 90 to 95%, for instance. Here I looked at the risk difference in some of the outcome measures between the high and low saturation groups. So we see that if a variable is above 0 here, it means that it favors high saturation targets. Here's the p-values, and you see that death is reduced in the high saturation targets, also necrotizing enterocolitis. On the other hand, ROP, and also BPD, at least it depends a little bit about the definition, but it's also increased in the high saturation target. Very recently, a long-term follow-up at 6 years of age came out from some of these, I think, the support data, where they looked at blood pressure. And fortunately, there was no difference in blood pressure between the high saturation target babies and the low saturation target babies. So oxygen targets between 91 to 95% increase ROP in need of therapy, but not severe vision injury. Oxygen targets of 85 to 89% increase mortality and necrotizing enterocolitis. And long-term follow-up does not show any differences between the 2 arms regarding death, disability, blindness, hearing loss, or blood pressure. But as I mentioned, I don't have time to show those results. Hyperoxia may lead to epigenetic changes in the lung. We don't know if they are transient or long-lasting. So I would just want to close very quickly, say a few words about congenital diaphragmatic hernia. As you all know, we should try to avoid bag and mask ventilation. So these babies should be intubated quickly, and an orogastric tube should be inserted. And we recommend to start resuscitation with 50% oxygen in these babies. We don't have big material, so this is not very strongly evidence-based, but it's more based on clinical experience. Target saturations are recommended to be between 85 and 95%. And if there is a persistent bradycardia or saturation is less than 80% at 5 minutes, increase FO2, and delayed cord clamping is also recommended, and avoid a peak inspiratory pressure of about 25 centimeter of water, and try to keep the PEEP pressure low. And finally, just quickly about primary pulmonary hypertension of the newborn, how should we oxygenate these? Well, it's recommended to keep the saturation in the high range here. So it's recommended to give 90 to 97% and keep a PO2, preductal PO2 of 55 to 80 millimeter mercury, that's 7.3 to 10.7 kilopascals. So just to summarize, I think that today we, to some extent, are able to individualize oxygen therapy of the newborn much more than we did 10 years ago. And every baby got the same 100% oxygen for newborn visitation, for instance. Now, for babies above 31 weeks, start with air. Between 28 and 31 weeks, start with air or 30% oxygen. Less than 28 weeks, start with 30% oxygen. It might be we need more, maybe 40%. We don't know yet. And for all gestation ages, adjust according to the saturation. And we recommend to start low and tighten it up, but there, of course, are different opinions about that. We need more randomized studies to really see what is the significance of a saturation above or lower than 80% at 5 minutes of age. Now, in the future, when we're talking about development of saturation, we have to also adjust for gender, CPAP, and cord clamping. Beyond delivery room, babies less than 28 weeks, targets of 91 to 95 or 90 to 94, which is the European recommendation. Very tight alarm limits because we want to avoid hyperoxemia. For congenital diaphragmatic hernias, start with 50% oxygen, and for primary pulmonary hypertension of the newborn, keep the saturation between 90 to 97%. So with this, I will thank you for your attention, and I would like to thank all my close collaborators. Thank you so much.
Thank you. Thanks a lot, Dr. Ola, for your nice presentation. We will take some question and answer after your second talk.
Doctor, sorry.
Yeah.
Sorry, doctor.
Thank you, Dr. Ola. We will take the question and answers after your second talk in the end of the session as a panel discussion. Dr. Peter Davis also going to be with us. So without further ado, I will introduce Dr. Peter Davis. He was with us yesterday also. Again, good evening, Peter. I think it's the evening in the Australia already. So Dr. Peter Davis is a director of neonatal medicine and the professor at the Royal Women's Hospital in Melbourne. He's led the Department of Newborn Research since 2009. He completed his MBBS at the University of Queensland and the fellowship at Buckmaster University. His interest in non-invasive ventilation, as we all know, he leads a team of enthusiastic clinical researchers interested in improving the care of babies. He's a substantial contributor to the Cochrane collaboration and a member of neonatal subcommittee of International Legion Committee on Resuscitation, which is ILCOR. Welcome back, Dr. Peter Davis. And then after the second talk of Dr. Ola, we will have a panel discussion as usual. Thank you. All yours, Dr.
David. Nice to be back with you again. And a great honour to be part of this conference, and particularly sharing the platform with my good friend Ola. I really enjoyed the last talk on oxygen. So we're going to switch tack slightly now and talk about postnatal steroids. And the question is what is the new solution for the old problem of bronchopulmonary dysplasia? I'd first like to just take a little diversion into what we might be able to learn from the antenatal steroid story. And I think we have something as neonatologists to learn from this story. And starting with the burden of illness, well, we know that respiratory distress syndrome is a big problem around the world. About 15 million babies a year are affected by RDS, and about 1 million of those die. And we know that the rates of respiratory distress syndrome increase as gestational age falls. So for babies less than 32 weeks, it's about 1 in 3 babies. By the time we get to our intensive care babies, those less than 28 weeks, it's 1 in 2. So a little bit of history of perinatal steroids. It was an accidental discovery. Montliggins in New Zealand was trying to induce labour in lambs, and found that if he used dexamethasone, that appeared to help the lung aeration of the newborn preterm lambs. And he and his colleague Howie went on to conduct the first randomised trial in humans of antenatal steroids in 1972. It seemed like there was a lot to be gained. It improved lung maturation, but he wanted to cover off on the potential risks of giving a powerful drug to a pregnant woman and fetus. And the risks were stillbirth, risks of maternal and fetal infection. Steroids, we know, impair growth, particularly of the brain. And we worry about giving steroids early in life because of the effects it might have in later life, as per the Barker hypothesis, leading to adult diabetes, adult diseases. We're going to be spending a bit of time at the Cochrane Library again tonight, and just to remind everybody that the Cochrane Library logo is based on the antenatal steroid story, and it's a very powerful and important story. This was what the evidence would have looked like after about 7 trials have been conducted on antenatal steroids, and this is the point estimate for mortality. Antenatal steroids were shown, or could have been shown, to be very useful in decreasing neonatal mortality if such a meta-analysis had been done. And it took the Cochrane collaboration to bring these trials together and get that very important clinical message out to the general public and into practice. So this is an example of what a very good systematic review looks like. It's got lots of studies in it, 30 studies, lots of women, more than 8,000 infants. So a very powerful database with which to work. Very important when we talk about systematic reviews and meta-analyses that we consider the quality of the studies going in. One of the main criticisms of meta-analysis is garbage in, garbage out. So we always should be looking at this aspect of the systematic review to gauge the quality of the studies going into the meta-analysis. And so if you look into a good systematic review, you'll find a graph that looks something like this, where the various qualities of the individual studies are evaluated for things like true randomization, blinding, and outcome data reporting. This is what it looks like for the antenatal steroid review. Most of this diagram is colored green or yellow, indicating a low or unclear risk of bias. Where you see a lot of red on the diagram, then you need to worry that this might not be an informative review. So just quickly going through the results, the initial finding of a reduction in neonatal deaths with antenatal steroids has been confirmed with subsequent studies. This is a major reduction, a 30% reduction. We talked about I-squared statistics, that measure of consistency between trials is quite low, so we can be quite confident in the outcome or the implications of this forest plot. Antenatal steroids reduce the rate of neonatal deaths. We're worried about, would it increase the risk of stillbirth? No, it doesn't. There's absolutely no difference in rates of fetal death. How important are the non-mortality outcomes? Well, we know that antenatal steroids reduce the need for respiratory support, a substantial risk reduction, a statistically significant, clinically important reduction in the need for ventilation, also economically important. Bronchopulmonary dysplasia does not change with antenatal steroids, and the theory here is that we're shifting babies from mortality, we're saving their lives, but perhaps increasing their risk of BPD. Other outcomes favorably affected: intraventricular hemorrhage, necrotizing enterocolitis is reduced with antenatal steroids. And although the data are somewhat limited, the New Zealanders have followed their babies randomized in these early trials into adulthood and allayed our fears that the steroids might be causing long-term harm. So they looked at the risk of diabetes, no difference. They looked at growth parameters into adulthood, no differences in height, weight, and head circumference. No problems with hypertension. The children exposed to steroids achieved as well as those not exposed in later life, and there were no problems with either lung function or bone density. So, in summary, this is a very brief overview, and there are lots of subsets to consider, but antenatal steroids save babies' lives. They do not seem to increase the risk for either mothers or the fetus. They have important economic benefits. They reduce the need for respiratory support. They reduce morbidity in the neonatal intensive care unit in the form of brain and gut morbidity, and they carry no important risks into adulthood. So when we turn to postnatal steroids, the picture is a little bit more blurry. And to summarize the effect, the risk-benefit ratio, it seems to vary with the timing of the steroids, the baseline risk of the population, and the route of administration of the steroids. So we'll go through those points one by one. So with respect to timing, the Cochrane authors have divided up their reviews on systemic postnatal steroids into early versus late. So early is defined as being administered in the first 7 days. The idea here being that if we give steroids early, we're giving them prophylactically to dampen down early inflammation in a baby's life, and therefore confer long-term benefits, hopefully. This systematic review includes 32 studies, more than 4,000 babies, and the evidence quality is high for the important outcomes. The results, no difference in mortality, but some benefits. If you give steroids early, prophylactically, you will extubate babies more quickly. You will reduce their rates of bronchopulmonary dysplasia and reduce their rates of symptomatic patent ductus arteriosus. On the downside, and there are important downsides, important associated adverse effects, there are increased risks with postnatal steroids given early in terms of gastrointestinal bleeding, intestinal perforation, hyperglycemia, hypertension, and growth failure. But the thing that has really damaged the reputation of early steroids is this association with long-term neurological harm, and in particular, an increased rate of cerebral palsy. Doesn't seem to affect death or major disability in the long term, but does seem to cause increased risk of cerebral palsy. The authors of this review noted that the harm was mainly associated with dexamethasone and not so much with hydrocortisone. At the end of their review, the authors concluded that early steroids, the benefits might not outweigh the risks. They suggested that we needed more long-term data And if more trials were to be performed, then they said, do them on hydrocortisone rather than on dexamethasone, and follow the babies up into later childhood. And this led to an important trial, a Premiloc trial, a French trial, which evaluated the effect of low-dose hydrocortisone in extremely preterm infants. And this was reported in The Lancet about 4 years ago. This was a double-blinded, multi-centered, randomized controlled trial, so generating high-quality evidence. It recruited babies at highest risk of bad outcomes, those less than 28 weeks, and they were recruited in the first 10 days of life. The intervention was 1 milligram per kilo of hydrocortisone for the first 7 days of life, followed by a lower dose, 0.5 milligrams per kilo for the following 3 days. Unfortunately, this trial was stopped early at only 2/3 of its planned sample size due to financial and technical support limitations. We would read that as they ran out of money. Their results, though, are important. There did seem to be an improvement in survival without bronchopulmonary dysplasia in the hydrocortisone group, roughly 9% improvement, and a p-value of 0.04. Mortality rates not significantly different. BPD rates not significantly different. Secondary outcomes, the hydrocortisone exposed babies certainly seem to come off the ventilator more successfully, 60% extubated by day 10 versus 44 in the placebo arm. Less problems with surgical patent ductus arteriosus, reduced from 21% to 15%. Long-term follow-up was not perfect and did not show any significant differences between the two groups. Now, this trial has been included in an individual patient meta-analysis, which is really dominated by that French study, but led by Michelle Schaffer and Christy Watterberg. They found 5 eligible randomized trials. One of the problems with these trials is that they are contaminated by a high rate of open label corticosteroid use in both arms. So 40% of all babies in these trials were exposed to open label corticosteroids. What they found was that early low dose hydrocortisone in the first 2 weeks of life increased survival without BPD at 36 weeks, 46% versus 53%. No significant difference in mortality, but a reduction in BPD, decreased death before discharge, and decreased PDA treatment. No difference in the important outcomes of days on ventilation, on CPAP, on oxygen, and the need for babies to go home in oxygen. On the downside, and this is an important downside, there was an increased rate of gastrointestinal perforation with early low-dose hydrocortisone and an increased risk of late onset sepsis, both bad outcomes that we try and avoid. No difference when they pooled all the data together in long-term neurodevelopmental outcomes, and in particular, no difference in rates of cerebral palsy. Now, some units have taken this as evidence that we should be giving early postnatal hydrocortisone. For us in Australia, we've taken a fairly cautious interpretation to these results. It's a modest and imprecise effect, dominated by one trial. And we do have lingering concerns about exposing all extremely preterm infants to early systemic corticosteroids. So we're going to go back now to late systemic steroids, those prescribed beyond the first week of life. Here we've got fewer infants, 1,400 infants. These are small studies, so 21 studies. The quality of evidence, however, is high for the important outcomes. We just quickly go through these. No significant difference in rates of mortality to latest follow-up. Postnatal steroids given late do reduce rates of BPD by about 25%. They do decrease the risk of babies needing to go home on oxygen. They do reduce the combined outcome of death or BPD. They do get babies off the ventilator sooner, but they are linked with these same side effects, these same adverse effects that we've seen before: increased risk of hyperglycemia, increased risk of hypertension, and a borderline increase in risk of gastrointestinal bleeding, all important outcomes. Going back to long-term outcomes, no evidence of benefit or harm when it comes to cognitive function or to cerebral palsy. So late steroids did not appear to influence those particular outcomes. Combining any major neurodevelopmental disability, again, no difference between steroid and control babies. Death or major disability, no difference. So the authors of this Cochrane review concluded that the benefits of late steroids may not outweigh the risks, that they may reduce mortality without increasing long-term neurodevelopmental risks, but the quality of the studies is limited. And the suggestion for us as clinicians is that we reserve late steroids for infants unable to be weaned from mechanical ventilation, and that when we do that, we should minimize the dose and the duration of steroid therapy. This is what we did in the DART trial, which was an interesting experience. This was a trial led by Lex Doyle, my colleague in Melbourne. This is a regime that's now fairly commonly used around the world. This is the DART regime, starting at 0.15 milligrams per kilo per day and giving a total of 0.89 milligrams per kilo over 10 days. We had to stop this study early because of lack of equipoise amongst the units at the time. This was at the time when steroids were being linked to cerebral palsy, and so people were understandably reluctant to recruit to this trial. But these are the demographic characteristics of the babies, mostly inborn. These are quite immature babies, 24, 25 weeks gestation. They're small, around the 600 to 700 gram mark. Most of these babies are being intubated in the delivery room, given surfactant. They're being recruited in the 3rd or 4th weeks of life and coming onto steroids with high respiratory requirements, babies in almost 50% oxygen on average. So these were fairly sick babies. We had to stop early, but we did get some interesting information. The first thing was that this low dose, short course of steroids did get babies off the ventilator more effectively. Here are the babies coming off the ventilator on dexamethasone. Babies on placebo tended to stay on the ventilator. So the outcome of failure to extubate by day 10 was much lower in dexamethasone group. So 60% of the babies had come off in the dexamethasone arm versus only 12% in the placebo arm. The other outcomes were not statistically significant. There was a reduction in mortality rate in dexamethasone group, but this was not statistically significant. No other important differences found. We did follow these babies up long-term just to look for evidence of harm from the dexamethasone group, but in fact, the rates of cerebral palsy were in fact lower in the dexamethasone group, but not statistically significantly different. Why is this so? Why were the results different for different trials of steroids? And the late Jack Sinclair had a creative way of attacking this problem. He postulated that the baseline risk for bronchopulmonary dysplasia might be an important determinant of the treatment effect of dexamethasone on this combined outcome of death and cerebral palsy. And the hypothesis was that steroids are more likely to do harm when the risk of bronchopulmonary dysplasia is small. And he suggested a method of attacking this problem statistically called a weighted meta-regression analysis. And I'll show you what that looks like shortly. So into this meta-regression, we were able to put in 20 studies with more than 2,000 babies, a mixture of early treatment and later treatment trials. And this was the result. And it's an interesting graph that requires some explanation. What we have on the x-axis is the rate of bronchopulmonary dysplasia in the control group, going from 20% up to 80%. On the y-axis, we have the effect on cerebral palsy. Above this line of 0, the result favors the control group. Below the line favors the corticosteroid group. Each of these circles is an individual trial. Big trials represented by big circles, small trials by small circles. And so what you can see is that as the rate of bronchopulmonary dysplasia in the control group goes up, the postnatal dexamethasone goes from causing harm to causing benefit. So babies beyond a baseline risk of about 50 to 60% risk of BPD are more likely to benefit from postnatal steroids. It lowers their rate of that bad outcome when the babies are at high risk of BPD to start with. Babies at lower risk, it's more like the steroids are more likely to cause harm. We repeated this a few years later, and the relationship held up very strongly. Still this cut point of about 50 to 60% BPD rates. Beyond that, you're more likely to do good than harm. So in an effort to maximize the benefit and minimize the risk of postnatal steroids, people have thought about giving the steroids more directly to the lung. And the question of inhaled budesonide has been addressed in an important trial by Basler and colleagues, published a couple of years ago. Very promising trial. Give inhaled budesonide straight to the lungs, avoid the systemic effects, but get the pulmonary effects. This was a randomized trial, more than 800 babies, high-risk babies, 23 to 28 weeks, and doing the right thing, following these babies into childhood and looking for important neurodevelopmental outcomes. And there was a reduction in the rate of the primary outcome, which was death or BPD, from 46% in the placebo group to 40% in the budesonide group. This is of borderline statistical significance. This is a very interesting trial because the two components of the primary outcome went in different directions. So the rate of death was slightly higher in the budesonide group, so it was doing harm in terms of death, but be doing good in terms of reducing bronchopulmonary dysplasia. Neither of these two results was statistically significant, but this is the hospital outcome. People were a little bit concerned about this increased risk of death, even though it wasn't statistically significant. As I said, they followed their children up to 18 to 22 months and found no important differences between the two groups. Where it became interesting was the rate of death in the longer term follow-up group. The difference between the two groups was greater, 5%, and now became statistically significant. So in spite of the early potential benefits, we saw that in the longer term, mortality was increased by the use of budesonide. And so the interpretation for the clinicians is that, unfortunately, inhaled steroids are not the solution. Which brings us to the next promising development, which is mixing steroids in with the surfactant that we give in the first hours to days of life. And pioneering this effort has been Dr. Ye in Taiwan, who has randomized many babies, but particularly in this study, he's randomized 265 babies, less than 1,500 grams. These are tiny babies on fairly heavy ventilation. They're in more than 50% oxygen in the first 4 hours of life. And he's mixed budesonide with Savanta, and the control group got Savanta alone. They kept giving these solutions until the oxygen came down below 30%. Most of the babies had 1 or 2 doses. And this result was quite promising. In fact, it was quite remarkable. A major effect in reducing death or BPD from 66% in the control group down to 42% in the treated group. And that's a highly statistically significant effect. It was found in conjunction that there was a lower oxygen requirement during the first week of life, so an early effect. No adverse effects in terms of the things we'd seen before, gastrointestinal bleeding, hyperglycemia, etc. There seemed to be a mechanism of benefit in that the markers of inflammation were reduced in those first days of life, lower interleukin levels. They did follow up some of their survivors and found no difference in either neurodevelopmental outcomes or growth outcomes. So a remarkably effective treatment found in a fairly modest number of babies. So there are some concerns about the sample size and the effect size here. Other questions about the type of surfactant that was used. We're not using Savanta anymore, and it's less commonly used around the world. It does require a larger volume than some of the alternatives. There were fairly restrictive inclusion criteria. If this treatment works, we'd like to give it to our more well babies at lower risk of a bad outcome. There were some questions about the quality of the study in terms of the lack of placebo and unclear blinding, and some questions about the long-term follow-up. So a promising treatment, but still work to be done. And with that in mind, I'm just going to give a quick advertisement for the randomized trial that we're conducting, which is a combination of surfactant and budesonide. We're using Curasurf. We're aiming for 1,000 babies, and we're about a quarter of the way there. Be delighted to hear if anybody would like to help us complete this trial. So just going to conclude there that postnatal steroids, yes, they have a role, but I think they should be reserved for babies at the highest risk of death or BPD. Of the newer strategies that are coming on, it looks to us like the combination of surfactant and steroids is the most promising, but this requires further testing before we use it as a standard therapy. So thanks very much for listening and watching. I look forward to your questions later in the session. Thanks very much.
Thank you, Dr. A very comprehensive review on the steroids, and already we have a few questions about that. So again, it's my pleasure to introduce Dr. Ola Segerstedt for his second talk, delivery room handling of the newborn. So Dr. Ola, the floor is all yours. I should say the screen is all yours. Okay.
Yeah. Do you see my slides now?
Not yet. If you can share your screen.
Yeah, that's what I'm doing, but I am. Okay, I try again.
Holding slide, please.
Share. That was my former lecture. pleasure to listen to Peter Davies. I remember 3 years ago we were in Abu Dhabi together. You remember, Dr. Junaid, had a very good time together in Abu Dhabi. So in this second lecture, I will talk about delivery room handling. And again, my outline is probably too busy, but I will not have time to cover all these aspects in detail, but some of them during the next 30 minutes or so. So when we talk about delivery room management, we often talk about the golden minute or the golden minutes. What we're doing in the delivery room is so important for the outcome of the baby. And I have put some of the therapies and factors that influence the baby's outcome here. But of course, also antenatal factors are of importance for what we're doing in the delivery room and also for the postnatal care and the final outcome. I would like to share with you some relatively new data from the European electronic database for preterm babies, the e-newborn. We published some of these data last year in Pediatric Research. And this database contains almost 40,000 babies, preterm babies, less than 32 weeks, born between 2014 and 2016. And here you see how the distribution of gestational age is with a peak at 31 weeks. When you look at mortality, we see this beautiful, I say beautiful curve. It's an exponential increase in mortality with decreasing gestational age. And here we have the odds ratios for mortality in relation to gestational age. Now, what we also, excuse me, what we also could show was that there is a gender difference regarding survival. And that is not a surprise. We've known that for years. But here we can clearly see and demonstrate that girls are doing better than males. And also regarding growth retardation, we find that if there is a small for gestational age babies defined as those below the 10th percentile, they have an increased risk of, a modest increased risk of mortality. However, when you're talking about extreme SJs less than the 3rd percentile, you see that mortality increases substantially to between 4 and 5 odds ratio. Now, 10 years ago, ILCOR in their recitation algorithm introduced the term the golden minute, the first 60 seconds after birth. And that raises a very important question which ILCOR didn't address, and that is, when is the golden minute? And I started to ask people, and I started to look into the literature to see when different groups were starting the clock. And I got very different answers. Some said or wrote that when the shoulders are out, we start the clock, and some said when the cord is cut. And of course, that doesn't make any sense today when we are practicing delayed cord clamping. And others said, well, when the baby is on the recitation table, we start a clock. And I have to admit, in my own practice, very often I start a clock when the baby was in my hands. But the right answer is when the whole baby is out. And this is very important because when we're talking about these golden 60 seconds, we have to know exactly which seconds we are talking about. Also because we are making an APGAR scoring. So if we look closer at the golden minute, it was split up in 2 halves in 2010. So during the first 30 seconds, you're supposed to dry the baby, warm it, wrap it in plastic if it's less than 28 weeks, stimulate it to breathe if it doesn't breathe, and position the airways correctly, and also record heart rate and breathing rate. And within the first 60 seconds, the golden minute, you should have initiated respiratory support if that is needed, and also put on a pulse oximeter if that is available. Now, is that possible to achieve? Well, there's studies from Colm O'Donnell's group showing that it's very difficult to achieve that within the golden minute. And we very recently published this communication to recitation just a few weeks ago, where we tried to summarize some studies using the Helping Babies Breathe project. See, when did I start ventilation? And you see here, these are studies from Tanzania, Uganda, Nepal, and again Tanzania. And you see there's a wide variation, but if you look at this Petrovic study from Uganda, they started in mean at 68 seconds, Nepal 71 seconds. It means that it is possible to start the first ventilation around the golden minute, but it's difficult to start within the golden minute. So if we go back to this delivery room management, I mentioned that other factors are important for what we're doing in the delivery room. For instance, the mother's BMI, body mass index, the use of antenatal steroids, as Peter Davis talked about, and also mode of delivery. And just want to show you very briefly why this is of importance. So we published quite a large meta-analysis in JAMA some years ago now, where we were able to show that there is a relation between the mother's BMI at the beginning of the pregnancy and perinatal mortality, as shown here. And we found exactly the same relation for fetal death and neonatal and infant mortality. So this indicates that it is important that the mother keeps her BMI, let's say, around 25, not too much above that, at least before they become pregnant. So this is important for us to know about. What about the use of antenatal steroids? Now we go back to the e-newborn database. So what we found here was that for babies about 23 weeks, more or less all of them were given steroids, 95%. But not all of them got a complete course. Approximately 20%, a little bit less, got an incomplete course. Does it matter? Well, when we looked at risk of death, we see that there is a clear effect of antenatal steroids. And you see that there is not a big difference between those who got a complete and an incomplete course. And this tells us that even if you don't have sufficient time to give steroids before 24 hours before delivery, you should still do and give it, I think. Well, mode of birth and neonatal outcome is well known. C-section affects the outcome. And this is a study from Yi and coworkers some years ago now, 6 years ago, but it shows that when C-section rate is above 10%, it doesn't affect mortality anymore. So based on this, and when we're talking about mortality, the optimal C-section rate is around 10, maybe up to 15%. Of course, when we are talking about morbidities, it could be different, but I think this is important to keep in mind because C-section rate is way too high in most places in the world. And just to remind you that after C-section, morbidity is higher. So here we have listed or put up according to gestational age. You see that after C-section, more babies go to the NICU, more TTNs, RDS, CPAP need, and hypoglycemia. And this is, of course, well known, but it's important to keep in mind. So let's turn to this question. How should we assess heart rate immediately after birth? Well, ILCOR in 2015, they suggested that the heart rate immediately after birth should be determined by ECG. What about other methods, palpation, auscultation by stethoscope or pulse oximeter? Well, if you look at the relation between heart rate assessed by pulse oximetry and ECG, you find this very nice correlation here. However, you see that some of these babies with a high heart rate, according to ECG, have a low heart rate with the pulse oximeter. So the pulse oximeter seems to underestimate the heart rate for at least some of these babies. Camlin and co-workers and Peter Davis is also a part of this study. They compared palpation, auscultation with ECG, which is this line here. And you see that both auscultation and palpation underestimates the heart rate immediately after birth. And this is another study showing that pulse oximeter, the blue symbols here, also underestimates the heart rate compared to ECG, especially in the low heart rate intervals. So Camlin and co-workers concluded that heart rate by auscultation is inaccurate and underestimates the heart rate obtained by ECG, which I think is correct. But together with Roger Soll, we said that we wrote a commentary and suggest that instead of counting heart rate only 6 seconds, you could count it 10 seconds, and maybe much of this inaccuracy could be eliminated. Well, a reliable heart rate is obtained earlier with ECG than with pulse oximetry. For instance, in one study, it was a difference of 84 seconds, which is substantial. On the other hand, quite a few of these ECG signals so far are excluded due to technical problem. And we also have the problem with pulseless electrical activity. But fortunately, new devices are under development based on, for instance, Bluetooth technology, and some of these have been tested out already. And I think that we, in the future, will get more accurate methods to assess heart rate. Well, 4 years ago, Roger Soll and I, we wrote this, and that auscultation is still the gold standard for assessing heart rate at birth. It was a kind of criticism of the ILCOR suggestion of ECG, which we think was premature at that time. Now, what about suctioning of babies? Well, already in 2010, ILCOR wrote that routine suctioning for infants born with clear or meconium-stained amniotic fluid is no longer recommended. So I think before that, and when I was in training, we suctioned the babies a lot. I think the reason we shouldn't suction is shown here, and it shows that the saturation, oxygen saturation, is decreased at least 6 minutes if you suction routinely compared with no suction. So maybe you don't need to suction, you could just wipe the mouth and the nose with a towel, a cloth, and this is what they tested out in Vallecano's group, published in Lancet some years ago. The outcome here was respiratory rate after birth, and you see there's no difference whether you wipe or you suction. These are babies about 35 weeks gestation. So I showed these data to our midwives, and they didn't understand. Well, we have been wiping for years. We have stopped suctioning many years ago. But still, I think many places in the world, many of the newborns are suctioned too much. So what is the need of resuscitation? Again, we can go to this e-newborn database. And what you see here is that for babies, 24 weeks and 25, 26, almost all of them need some kind of resuscitation. And then you see the need decreases with gestational age. But we have to distinguish between so-called basic resuscitation, which is defined as use of bag and mask plus oxygen if needed. And then you see a different picture. You see that the most immature ones, they're not resuscitated with basic resuscitation, but that the need of that increases, of course, with gestational age. The smallest one, they need advanced resuscitation, which is in addition to bag and mask, oxygen, intubation, chest compressions, adrenaline, and probably also volume. Very rarely needed though, but you see that advanced resuscitation is very common for the most immature, and then about 30 weeks is not very common anymore. Now, what is the prognosis if a baby needs basic resuscitation? Well, fortunately, we couldn't find any increase in mortality. However, as soon as a baby needs advanced resuscitation, mortality is increased approximately twofold. So that is decreases or reduces the prognosis for these babies. A few words about sustained inflation. In a rather recent Cochrane review, and Peter Davies also contributed to that one. I think he's contributed to so many Cochrane reviews in our field. Well, anyway, these authors, they concluded that sustained inflation was not better than intermittent ventilation for reducing mortality. Need for intubation, need for or duration of respiratory support or bronchopulmonary dysplasia showed there was no evidence of benefit for sustained inflation over intermittent ventilation. However, they found that the duration of mechanical ventilation was shortened in the sustained inflation group, but the authors said that the results should be interpreted with caution. So we need future randomized controlled trials, and one such trial was the so-called SAIL study, which was stopped prematurely due to adverse effects, higher mortality in the sustained inflation arm. So here is the SAIL study, where babies in the sustained inflation group received 2 blows of 15 seconds with a peak pressure of 20 and 25 seconds. So what I found was that early death was significantly increased from 2.1 to 9.1%. So that was the reason this study was stopped. And now I'll talk about cord clamping, and that has been a hot topic for several years now. If you look at how blood is transfused from the placenta to term babies, you'll see that within 60 seconds, approximately 70% of the blood has been transfused. And that is the reason, if you look into guidelines of cord clamping, you see that most guidelines say that delayed cord clamping is defined as 30 or 60 seconds of delay. So here are some recommendations from different societies, and you see that 30 to 60 seconds is what is recommended, especially for preterm babies. Now, in order to study this, the Australian placental transfusion study, the APT study, was carried out and was published a couple of years ago. And in this study, preterm babies born before 30 weeks were randomly allocated to immediate cord clamping, that is within 10 seconds after birth, versus delayed cord clamping, 60 seconds or more. And primary outcome was death at 36 weeks of gestation. It was a large study, 1,600 babies. So this is what they found regarding the primary outcome, which was death or major morbidity by 36 weeks of postmenstrual age. Absolutely no difference between the groups here, as you can see here. However, when they looked at mortality separately, they found a 30% reduction in mortality in the delayed cord clamping group. So these same authors, they carried out systematic review and meta-analysis, the same field. So babies less than 37 weeks, they found studies where babies less than 37 weeks, where they had either been, the cord had been clamped after 30 seconds without cord milking, or immediate cord clamping, now defined as less than 30 seconds. So this is what I found regarding mortality, the same as in the APT study, a 30% or 32% reduction in mortality if you delay the cord clamping. So this was, of course, a very important study. Secondary outcomes show that delayed clamping reduced the number of blood transfusions needed, but it increased the incidence of polycythemia and also of jaundice. Now, a new aspect of cord clamping I would like to emphasize is that late clamping increases the saturation. This is from a study from Nepal, very recently published, and showing that if you delay cord clamp, the saturation up to 5-10 minutes is higher than if you practice early clamping. So if you look at the so-called development of oxygen saturation by the Dawson curves, which were published some 10 years ago, and compare with, this is the Dawson curves, this is the black solid line here, and compare it with what you find after delayed cord clamping. This is from a very recent study from Max Vento's group in Valencia, and it's the blue line here. So you see that the first minutes of life, the saturation is higher after delayed cord clamping. And if you see that those babies who do not reach a saturation of 80%, you see that there are less in the delayed cord clamp group, although after 5 minutes, it's not a big difference anymore between the groups. For heart rate, the difference is not very typical. It's not very substantial, I mean, except for the first maybe minute or so, where the heart rate is higher after delayed cord clamping compared with early clamping. Should we resuscitate with an intact cord? This question has been asked now for several years, and Kateria and co-workers in San Diego, they carried out a randomized trial, babies between 23 and 31 weeks of gestation. And here, you know, this very busy panel, but it's a lot of hemodynamic variables. So to make a long story short, they didn't find any difference in any of these variables: blood pressure, cerebral oxygenation, arterial oxygenation, respiratory rate, etc. So these authors concluded that it is possible, it is feasible to ventilate with an intact cord, but there was no measurable clinical improvements according to these data. What about cord milking? Well, you can milk the cord. You cut the cord first at about 25 centimeters from the umbilicus, and you should do that within 30 seconds after birth. And people have said that maybe this is an alternative to waiting for 1 minute before you clamp the cord. You can milk it 3 times at the speed of 10 centimeters per second. I recently saw a study where they recommended 5 times milking. Now, cord milking versus immediate cord clamping for immature babies demonstrated a need for less transfusions the first 28 days, a higher hematocrit, and also less intraventricular hemorrhage, grade 3 and 4, which, or totally 25 versus 51, grade 3 and 4 was not a big difference. Cord milking versus delayed cord clamping showed that it was as efficient. Both of them seemed to be quite equal in this study here. But then Kateria carried out a new study, cord milking versus delayed cord clamping, babies between 23 and 27 weeks of age. And what you see here is that the cord milking group had a significantly higher risk for severe intraventricular hemorrhage. So what happens is that when you're milking the cord, the increased venous return to the right atrium enters the aorta. As you know, there's a pulmonary vasoconstriction, so it goes up to the brain, and lack of cerebral autoregulation and right to left ductal shunt result in fluctuations in flow to an immature brain with fragile germinal matrix. And this may be the mechanism for increased risk of intraventricular hemorrhage. Now, Kateria did a follow-up to make this more complicated follow-up of his data, and he actually found a higher cognitive score after cord milking. But still, I think most of us would say we don't want to recommend cord milking for these immature babies because of the risk of intraventricular hemorrhage. And now these days, people are talking about physiological cord clamping. You should ventilate and then cut the cord. And this concept has been taught us a lot from Stuart Hooper in Melbourne. And this is from one of his animal experiments showing that if you cut the cord before you start ventilation, you get this increase in arterial pressure. If you wait to ventilate, wait to clamp the cord after ventilation, you get this more smooth transition. Today, I think more and more are suggesting that we should use this more physiological approach. Just finally, a few words about heat loss and temperature control. Now, ILCOR emphasizes this a lot, and in the 2015 algorithm, they introduced this temperature line just to remind us that we should maintain the temperature throughout the whole procedure in the delivery room. So for the smallest babies, in order to prevent heat loss, we put them into plastic. We wrap them or put them into plastic bags. And here is a Cochrane review published a couple of years ago, showing that, yes, by doing that, you keep the body temperature at a more correct level, as shown here. And also, later on, during stabilization, the temperature is kept within the interval we want to keep them. However, when we look at more important outcome measures as brain injury, there's no difference whether you wrap into plastic or not. And when you look at mortality, again, there's no difference. So if you wrap babies 28 weeks or less into plastic, it leads to higher temperature at admission with less hypothermia. But you have to remember that you should be very careful with this because it might induce iatrogenic hyperthermia, particularly if you're also using thermal mattresses. together with putting them into plastic. This Cochrane review concluded that there is limited evidence to suggest any benefit and no evidence of harms for most short-term morbidity outcomes known to be associated with hypothermia. Many observational studies have shown increased mortality among preterm hypothermic infants, yet evidence is insufficient to suggest these interventions reduce risk of in-hospital mortality. Hypothermia may be a marker for illnesses and poorer outcome by association rather than by causality. Should we stop putting these babies into plastic or wrap them into plastic? I don't think so. I think we still should do that, because even if this Cochrane review didn't show any major difference in major outcome measures, I think we should strive to keep these babies in the thermoneutral interval. So here are the recommendations, the European recommendation from 2006 to 2019. Keep the babies, the core temperature between 36.5 and 37.5. American Academy of Pediatrics recommends babies less than 32 weeks, the delivery room temperature should be 23 to 25, and resuscitation guidelines recommend babies less than 28 weeks, a temperature of 26 degrees. The obstetricians think that's too hot, I think, and objects to that. And very finally, I just want to show you guidelines from World Health Organization 2015, where they advocate kangaroo mother care. It should be promoted. And even intermittent kangaroo mother care is of use and should be promoted, I think. So I'll end up with the delivery room stabilization recommendations from Europe, published a year ago. And in these recommendations, we suggest or recommend delayed cord clamping for at least 60 seconds. We haven't introduced physiological cord clamping yet, but I guess perhaps in the new edition coming out in 2022, this will be introduced. Oxygen I talked about in the first lecture. It should be controlled by using a blender. An initial FiO2 of 30% is appropriate for babies less than 28 weeks gestation. I have to add that maybe it should be higher, maybe 40%, we don't know. 21 to 30% for those between 28 and 31 weeks, and adjustments guided by pulse oximetry. CPAP, I didn't talk about that, but we recommend the CPAP of 6 to 9 centimeter. Water via mask or nasal prongs. We do not recommend sustained inflation. And we also recommend that intubation should be reserved for babies who have not responded to positive pressure ventilation via face mask. Plastic bags or occlusive wrapping under radiant warmers should be used during stabilization in the delivery suite for babies less than 28 weeks gestation to reduce the risk of hypothermia. So here, this final slide kind of summarized some of the topics I have discussed in this lecture. So here is about umbilical cord clamping, summarizing the Australian placental transfusion trial. Here is Kateria trials, cord milking summarized. Here we have summarized some of the studies regarding use of oxygen by Owe and colleagues from Sydney. And here's the SAIL trial and the Neoprom trials, which I talked about previously. So thank you so much for your attention.
Okay, thank you, Dr. Ola Segerstad. I think we have time for the Thank you, Dr. Ola and Dr. Peter Davis. A very nice session. It's a lot of questions. I don't know if we can cover all, but actually, many of those questions directed towards both of you. So whoever chip in and answer. So anyway, we start with the first question. They want to ask about the FiO2 requirement at the chest compression. They want to know if during the chest compression, if they use less than 100% oxygen, is there any bad outcome? Is there any study about that? And what is your expert opinion about that? To use less than 100% oxygen during chest compression?
Yeah, maybe I could answer that question.
Sure.
Well, as you know, the guideline, ILCOR guidelines, at least the 2015 guidelines, still recommend to use 100% oxygen during chest compressions. I don't know, maybe Peter Davis knows the 2020 guidelines, but I haven't seen them yet. The reason ILCOR still recommend 100% oxygen for chest compressions is that we don't have any clinical studies. But recently, we and others, so we have carried out studies in newborn piglets with chest compression in newborn piglets, and we've been able to show that outcome is as good with air, starting with air, as with 100% oxygen. We even published a meta-analysis with these animal studies showing that with Schmelzer and co-workers, his group. Still, we need clinical studies, and I guess ILCO will not change the guidelines before we have clinical data. Maybe Peter could comment on that.
It's a very interesting question, isn't it? It's based on emotion and not on science. I was there when we were discussing at ILCOR this what should we use, and we have to admit that we do not know. We're worried about oxygen toxicity, but we're at a point where we're throwing everything at the baby. We're giving the baby chest compressions. We're intubating and ventilating the baby. Therefore, we should give the maximum amount of oxygen that we can. Now, that's not good scientific logic, and we must admit that. I suspect that we will be able to reconsider that recommendation as more animal work comes. It's going to be very difficult to do a randomized trial enrolling only babies that are having chest compressions. I think that's very difficult, but very difficult to move clinicians who are used to using 100% in that situation. So it's a difficult question. There is no evidence-based answer at this stage. I think you could argue either way, but for the moment, ILCOR is saying 100%, but not very confidently.
So I guess this means, Peter, that ILCO is not changing in the new guidelines.
It's not on the agenda, Ola. Yeah. We have another. The good thing about ILCOR now is that we're able to review things a little bit more swiftly. So if evidence becomes available in the next couple of years, it can come into recommendations fairly quickly, but there's no sign of that.
So we tried to launch a clinical study on this, but it's very difficult. I mean, we need a lot of babies. We probably need to be a multi-center study, but it is highly needed.
Yeah.
Sure. Okay, thank you. The second question is that somehow related to that pulse oximeter that takes some time to pick up. So how we can guide ourselves for target FiO2? And it has happened just yesterday in our unit that one of the pulse oximeter in delivery suites taking at least 1.5 to 2 minutes to pick it up. So both of you can comment on that.
Yeah.
You first, Ola.
Yeah, I mean, we know that, and then that's one of the drawbacks with the pulse oximeter, that it takes 90 seconds, sometimes up to 2 minutes before we get a good signal. But for the saturation, we don't have anything better, I think. But
Okay.
for the heart rate, as I showed, I mean, ECG is probably faster. We know it's faster, but also ECG has its drawbacks.
So, Dr. Peter, I will add for you, is there any consideration of using near-infrared spectroscopy in the delivery room?
We are not doing that, Junaid, but and I think my personal belief is that we probably need less technology rather than more in that first couple of minutes, right? If we're so focused on the number, we're forgetting to look at the baby, we're forgetting what the baby needs, and that's good ventilation, good mask position, and attention to detail with that for the first minute or two. So I'd much prefer people were focused on that than a number coming or not coming on a saturation monitor. And I think Ola might have alluded to this. One of the risks of getting an ECG reading very early on is we're not quite sure what to do with it. And people can leap a couple of steps ahead and start doing, for instance, cardiac massage when all the baby might need is a little bit of stimulation or perhaps some good quality ventilation. I don't know what you think about that, Ola.
I think that's a very important comment, and I completely agree with you. Absolutely.
Okay, so next is about steroids. So, Dr. Davis, what is your criteria for steroid for late preterm deliveries? So, for example, like 36-weeker who requires some oxygenation for a prolonged period of time. So, what do you think about that?
We're not big fans of using steroids at all. We really make the baby earn their steroids. So we would use them for hardly ever beyond the extremely preterm range. We use it for babies who are stuck on the ventilator and who have got quite reasonable oxygen requirements. So that's our particular approach. We would very rarely use steroids in the more mature baby.
And related to the same question, do you have a practice of administering steroids for extubation, like a pre-extubation steroid or DART therapy?
Yeah. For extubation, not typically for the first extubation, we would not be using steroids routinely. If a baby has had a previous extubation and they've failed because of stridor and evidence of cord swelling, then the next time we would give the baby steroids prior to extubation. Okay. For some babies who are stuck on the ventilator, yes, we would give steroids in an effort to wean and extubate them. So yes, that's a different question.
And the other question is, can we repeat that DART course? One course is enough or two courses? Any recommendation of that?
I rushed through that slide, but part of the DART protocol was if at the end of the 10 days of therapy, the clinician wanted to give another 10 days, that was fine. So I think about a quarter of the babies in the DART trial got a second round of 10 days of steroids. So we would use that in practice as well now, that if the baby is rebounding at the end of the 10 days, going back into more oxygen or threatening to go back onto the ventilator, we would restart the steroids and wean them down again.
You mentioned about budesonide nebulization. So is there any recommendation in the post extubation, after extubation of those babies?
I'm not aware of any studies of that. So we don't use it, and I wouldn't be recommending it.
Okay. Dr. Ola, the question is, when trying to cover the golden millet, do we get adequate time for assessing the step-by-step initial interventions? So the thing is that the golden millet is really a minute, and then step-by-step interventions as by the NRP algorithm. It is feasible or it can be done?
Well, the question is if it's too
adequate
or too ambitious, this golden minute. And I think there are studies, for instance, from O'Donnell's group in Dublin, showing that very difficult to achieve this, what we want during the golden minute. And also this I showed you the data from 4 studies showing that it's difficult to start ventilation within the first minute. So maybe the golden minute is not realistic, but I think still it should be a kind of a target, a goal. I would like to hear Peter's opinion about that, because I think this is an important question.
Colin O'Donnell was one of our fellows, and we love him dearly. And he's very much an iconoclast. He likes to poke at authority and anything that's rigid, like you must do this in 1 minute. He would be very much against, and I tend to agree with him. It's to instill a sense of panic in that first minute, to have a rush is probably not the way to go. We need to be calm and methodical and work through things logically, not be driven by the clock. Just do a good job, and that will probably take more than a minute. And I think you made a good argument that this trying to get everything done in a minute just doesn't happen. But it doesn't mean we take our eyes off the baby. It just means we keep our eyes on the baby and we work methodically through those steps, not paying attention to the clock necessarily.
But maybe, I think the introduction of the term the golden minute has been important, because it has taught us that we should focus on certain basic aspects the first minute. So maybe we should still talk about the golden minute, but we should know that maybe the golden minute is not 60 seconds, maybe it's 80 seconds or 90 seconds.
It doesn't sound as good, does it, Ole? The golden 85 seconds. It just doesn't have that same ring to it.
Yeah.
Dr. Ola, actually, you mentioned this, but I am repeating it. You mentioned in your talk, but the question is that in very premature baby, if we start from 21% and then titrate up, it is feasible, or we have to start with 30%? That's the question.
Well, we recommend now for babies less than 28 weeks to start with 30% oxygen. Okay. That's also the European guidelines. And what I said is that we don't know if this is the optimal. I don't think, my opinion is I don't think it should be 100%, but maybe it should be 40% or 50%. For babies between 28 and 31 weeks, we say 21 to 30% oxygen. And if you ask my personal opinion, I would rather start with 30% than air, I think, for also these babies. But we don't have, in my opinion, we don't have data to really say what is the better.
Okay, we have a lot of questions because of the timing. Our colleagues in the USA is waiting for the second session. They are going to be with us. But my last question to Dr. Peter Davis is my question. So when the PLUS trial will come out, or get some idea? What is the timeline?
We're about 2 years into a 4-year recruitment, Junaid, so we've still got a lot of work to do, but the babies are coming in. But this is a large trial, and large trials take time to complete. But hopefully I'll be able to share this with you in maybe 3 years' time.
Okay. Okay, so thank you once again, both of you. Very nice session, and I hope all the participants enjoyed it. Thank you, Dr. Ola. Thank you, Dr. Peter Davis. And inshallah, we'll meet you personally, not virtually.
I hope so. Thank you. Thank you so much for inviting me.
Junaid.
So thank you, ladies and gentlemen, and welcome back. And it's great to have you all today. Thank you to Dr. Khan for that amazing session and our two speakers. So without any further ado, I would like to acknowledge the companies and the organizations for their valuable support and contribution to the 10th International Neonatology Conference held right here in Abu Dhabi. I would like to thank ProLacta, MPC, CHIC, HESA Medical, Children's National Hospital USA, and Children's Hospital of Philadelphia, USA. Ladies and gentlemen, the conference is accredited by the European Accreditation Council for Continuing Medical Education for 18 CME hours, which is recognized by DOH Abu Dhabi, MOHAP, DHA, and GCC health authorities. CME hours will be calculated based on the number of hours spent streaming on the live platform. Also, ladies and gentlemen, do not forget we have also the most interactive person of the day by asking questions, visiting the exhibition areas, talking to company representatives, and using the online platform. And stay with us until the end of the day for you to win a smartwatch. So this is a great opportunity for you to be online and stay with us so you could win this great prize, which is a smartwatch. Also use the Ask a Question tab, which is in the meeting hall, for any questions related to the lectures. Our expert moderators and speakers will try to answer these questions for you. And you can do that during the panel discussions as well. Visit the sponsors' virtual booth at the exhibition hall. Delegates can chat and also use the video call option via the sponsors' chat box. The agenda of the conference can be accessed on either the bottom panel of your screen or the corner menus. Please feel free to navigate the online platform for maximum virtual experience. Today's program will end at 2025, so stay with us throughout the day and enjoy this awesome conference with such interesting topics. We'd also like to invite everyone to join the ProLacta workshop with Dr. Melinda Elliott and Dr. Andy McKell on nutrition in the NICU, which is also the topic of this talk is optimal use of the EHMD, which is exclusive human milk diet. So that will be at 17:45 to 18:30 on day 3, which is tomorrow. So ladies and gentlemen, we will take a short break and we will join you shortly. So remember to stay online and to visit the virtual platform and chat with the sponsors. We thank you once again for joining us and we will see you shortly.